Hi, this is Dr. Akhtar Amin and today's topic is herpes simplex keratitis and herpes zoster keratitis. So first of all, herpes simplex keratitis. Herpetic eye disease is the most common infectious cause of corneal blindness in developed countries. 60% of corneal ulcers may be the result of herpes simplex virus. 10 million people worldwide have herpetic eye disease. What is herpes simplex virus? It is enveloped with a cuboidal capsule. It has linear double-stranded DNA genome. It has two subtypes, HSV1 and HSV2. And these reside in almost all neuronal ganglia. HSV1 causes infection above the waist, principally the face, lips, and eyes. The HSV2 causes venereally acquired infection, also known as genital herpes. HSV2 is rarely transmitted to eye through infected secretions, either venereally or at birth. In case of neonatal conjunctivitis, HSV transmission is facilitated in conditions of crowding and poor hygiene. Primary infection without previous viral exposure usually occur in childhood, spread by droplet transmission, less frequent by direct inoculation. Due to protection by maternal antibodies, it is uncommon during the first 6 months of life, but occasionally severe neonatal systemic disease may occur, in which early diagnosis and intravenous antiviral treatment are critical to reduce mortality and disability. The presence of maternal antibodies means that dendritic corneal ulcers may be seen. Most primary infections with HSV are subclinical or cause only mild fever, malaise, upper respiratory tract symptoms. Blepharitis, follicular conjunctivitis may develop, but are usually mild and self-limited. Treatment, if necessary, involve topical acyclovir ointment for the eye, cream for skin lesions, and occasionally oral antivirals. Unfortunately, there is no evidence that antiviral treatment at this stage reduces the likelihood of recurrent disease. Recurrent infection. Recurrent disease is the reactivation in the presence of cellular and humoral immunity. It occurs after primary infection. After primary infection, the virus is carried to the sensory ganglion for that dermatome, for example, trigeminal ganglion. Here, latent infection is established. The latent virus is incorporated in host DNA and cannot be eradicated with presently available treatment. There is subclinical reactivation. It can periodically occur, during which HSV is shed. Patients are contagious. Clinical reactivation. A variety of stress factors such as fever, hormonal change, ultraviolet radiation, trauma, trigeminal injury may cause clinical reactivation. Fever, hormonal change, ultraviolet radiation, trauma, trigeminal injury may cause clinical reactivation. The virus replicates, transported in the sensory axons to the periphery during clinical reactivation. The pattern of disease depends on the site of reactivation, which may be remote from the site of primary disease. Hundreds of reactivations can occur during a lifetime. The pattern of disease, so it depends on the site of reactivation. While the rate of ocular recurrence after one episode is about 10% at 1 year, 50% at 10 years. The higher the number of previous attacks, the greater the risk of recurrence. Risk factors for severe disease may be frequently recurrent, include atopic eye disease, childhood, immunodeficiency suppression, malnutrition, measles, malaria, inappropriate use of topical steroids. It may enhance the development of geographical ulcer, which we will discuss. So, herpes simplex is the commonest infectious cause of corneal disease in developed countries. Now, epithelial keratitis. Epithelial keratitis may be dendritic or geographic. It is associated with active virus replication. The symptoms are mild to moderate discomfort, redness, photophobia, watering, blurred vision. Signs in chronological order are: there will be reduced visual acuity, there will be swollen, opaque epithelial cells arranged in a coarse, punctate or stellate pattern. Stellate means the spicules radiate out from the central mass. Stellate means the spicules radiate out from the central mass. So this is a stellate pattern. There is swollen opaque epithelial cells. They are arranged in a coarse punctate or stellate pattern. There is central desquamation result in linear branching, also known as dendritic ulcer. Dendritic ulcer, most frequently located centrally. The branches of the ulcer have characteristic terminal buds. These terminal buds and its bed stains well with fluorescein. Next, the virus-laden cells at the margin of the ulcer stain with rose bengal. Rose bengal. This may help distinction of herpetic ulcer from alternative conditions, particularly atypical recurrent corneal abrasion. The corneal sensation is reduced. Inadvertent topical steroid treatment may promote progressive enlargement of the ulcer to a geographical or amoeboid configuration. So this is caused by inadvertent topical steroid treatment. There is mild associated subepithelial haze. Subepithelial haze. Anterior chamber activity may be present but is usually mild. Anterior chamber activity is mild. Follicular conjunctivitis is treated with topical antivirals. Is caused by topical antivirals. So follicular conjunctivitis is treated, but it can also be caused by topical antivirals. Vesicular eyelid lesions may coincide with epithelial ulcer. Elevated intraocular pressure. It is not uncommon. Tonometry should be performed on the unaffected eye first in a disposable prism used. Following healing, there may be persistent punctate epithelial erosions. Irregular epithelium settle spontaneously, should not be mistaken for persistent active infection. Hold epithelial appearance commonly result from assiduous, especially prolonged topical antiviral instillation. Mild subepithelial haze may persist for weeks after the epithelium heals. In some cases, mild scarring may develop, tends to become more evident after each recurrence, eventually threaten vision. Recurrence may occur after a corneal graft undertaken for stromal scarring. Investigation is usually unnecessary as the diagnosis can be made clinically. Pre-treatment scraping can be sent in viral transport medium for culture. PCR and immunocytochemistry are also available. Janssen staining shows multinucleated giant cells. HSV serological titers rise only on primary infection. Can be used to confirm previous viral exposure. Used in cases of stromal disease when the diagnosis is in doubt. Treatment of HSV is predominantly with nucleoside which is purine and pyrimidine analogues that disrupts viral DNA. The majority of dendritic ulcer will eventually heal spontaneously without treatment, though scarring and vascularization may be more significant. Topical treatment. The most frequently used drugs are acyclovir 3% ointment, ganciclovir 0.15% gel, each administered 5 times daily. Trifluridine is an alternative, requires instillation up to 9 times daily until epithelium closes, then 5 times daily. The drugs are relatively non-toxic even when given for up to 60 days. They have approximately equivalent effect, acting preferentially on virus-laden epithelial cells and penetrating effectively into the stroma. 99% of ulcer heals within 2 weeks. Idozuridine and vidarabine are older drugs that are probably less effective and more toxic. Idozuridine and vidarabine. Debridement may be used for resistant cases. The corneal surface is wiped with sterile cellulose sponge or cotton tip applicator. Epithelium should be removed 2 mm beyond the edge of the ulcer, since involvement extends beyond the visible dendrite. The removal of the virus-containing cells protects adjacent healthy epithelium from infection and eliminates the antigenic stimulus to stromal inflammation. A topical antiviral agent should be used in conjunction. Signs of treatment toxicity include superficial punctate erosions, waves of walled epithelium, follicular conjunctivitis, rarely punctal occlusion. Absence of epithelial walling with a persistent epithelial lesion raise the possibility of poor or non-compliance. Oral antiviral therapy, acyclovir 200 to 400 mg 5 times a day for 5 to 10 days. Famciclovir, valciclovir is indicated in most immunodeficient patients. So these oral antivirals are indicated in most immunodeficient patients, in children and patients with marked ocular surface disease. Is effective alternative to topical treatment when the topical are poorly tolerated, when there is a resistance to topical. The newer oral agents may be better tolerated than acyclovir, require less frequent dosing. Optimal regimen are not yet defined. Interferon monotherapy does not seem to be more effective than antiviral, but the combination of nucleoside antiviral with either interferon or debridement seem to speed healing. Skin lesion may be treated with acyclovir cream 5 times daily as for cold sores. If extensive, an oral antiviral may be given. Cycloplegia homotropine 1% once/twice daily can be given to improve comfort. Topical antibiotic prophylaxis is recommended by some practitioners. IOP control. If glaucoma treatment is necessary, prostaglandin derivatives should probably be avoided. They may promote herpes virus activity and inflammation generally. Topical steroids are not used unless significant disciform keratitis is also present, which we will discuss. Slow healing or frequent recurrence may indicate the presence of a resistant viral strain. An alternative topical agent or debridement may be tried. In especially refractory cases, a combination of 2 topical agents with oral valciclovir or famciclovir may be effective. A significant minority of resistant cases are due to varicella zoster virus. Disciform keratitis. The etiology of disciform keratitis, also known as endothelitis, is unclear. It may be the result of active HSV infection of keratocytes or endothelium, or hypersensitivity reaction to viral antigen in the cornea. The symptoms are blurred vision of gradual onset, which may be associated with halos around lights, discomfort redness, but tend to be milder than purely epithelial disease. Past history of epithelial ulcer is not always present. Possibility of mimicking infection such as acanthamoeba fungal keratitis should be borne in mind. Signs. There is a central zone of stromal edema with overlying epithelial edema. The lesion is eccentric occasionally. There is large granulomatous keratic precipitates underlying the edema. Folds in the decimate membrane in severe cases. Folds in the decimate membrane, here you can see. Wesley ring is a surrounding immune ring of deep stromal haze. This Wesley ring signifies deposition of viral antigen in host antibody complex. IOP may be elevated, reduced corneal sensation. Healed lesions have faint ring of stromal, subepithelial opacification, thinning. Consecutive episodes may be associated with gradually worsening subepithelial stromal scarring and superficial or deep vascularization. Mid-stromal scarring from disciform keratitis is a cause of interstitial keratitis. Treatment. A broad approach to management is set out, but regimens should be tailored individually. Careful monitoring, adequate treatment depend upon severity of inflammation is critical to minimize progression of scarring. Patients should be cautioned to seek treatment in the first suggestion of recurrence. Though some authorities feel that minimal inflammation may not warrant treatment, can be addressed with cycloplegia alone. The initial treatment is with topical steroids, prednisolone 1%, dexamethasone 0.1%, with antiviral core 4 times daily. As improvement occurs, frequency of administration of both is reduced in parallel over not less than 4 weeks. It is prudent to keep steroid intensity and duration to the minimum required for effective control of inflammation. IOP should be monitored. Cycloplegia can be used to improve comfort if necessary. Subsequent prednisolone 0.5% once daily is usually a safe dose at which to stop topical antiviral core. Some patients require a weaker steroid such as fluoromethanol 0.1%, loteprednol 0.2% on alternative days for many months. Periodic attempts should be made to stop the steroid together. With active epithelial ulceration, it is reasonable to try to keep the steroid intensity as low as possible for adequate effect with a more frequent antiviral regimen. For example, initially topical antiviral 5 times daily with steroid 2 to 3 times daily, titrated according to the signs of activity of the both. Oral antiviral treatment may be helpful, but its efficacy in this situation has been not established. Oral steroids are sometimes used in severe stromal inflammation as an adjunct or to reduce steroid-induced IOP elevation and or to avoid viral promotion and infectious viral keratitis. Topical cyclosporine 0.05% may be useful, particularly in the presence of epithelial ulcer, to facilitate tapering of topical steroids such as steroid-induced IOP elevation. Fine needle therapy laser techniques have been reported for successful addressing the corneal neovascularization and improving vision. Next is necrotizing stromal keratitis. This is a rare condition result from active viral replication within the stroma. Though immune-mediated inflammation is likely to play a role, may be difficult to distinguish from severe disciform keratitis. Maybe a spectrum of disease include overlap with neurotropic keratopathy. As with disciform keratitis, a similar clinical picture may be caused by other infection. The signs are there is stromal necrosis, melting, profound interstitial opacification, anterior uveitis, capes underlying the active oral infiltration, epithelial defect, scarring, vascularization, lipid deposition. Treatment is similar to that of aggressive disciform keratitis. Oral antiviral supplementation, initially at the upper end of the dose range, is commonly used. Next is neurotropic keratopathy. We also discussed a separate topic. It is caused by failure of reepithelialization resulting from corneal anesthesia, exacerbated by other factors such as drug toxicity. There is non-healing epithelial defect after prolonged topical treatment. It is an early sign. Stroma beneath the defect is grey opaque, may be thin. Secondary bacterial fungal infection may occur. Treatment is that of persistent epithelial defects. Topical steroids to control any inflammatory component should be kept to a minimum. Iridocyclitis. Herpetic iridocyclitis can occur without signs of active corneal inflammation associated with direct viral activity. IOP elevation is common, presumed to be due to trabeculitis. Steroid-induced IOP elevation may also be relatively common. Etiology may be missed unless there is a history of previous herpes simplex keratitis. Patchy iris atrophy, here you can see, may provide a clue. Transillumination may demonstrate subtle lesions. Aqueous sampling for PCR is diagnostic. Treatment is primarily with topical steroids. Oral acyclovir may be given. Other considerations: long-term oral acyclovir reduces the rate of recurrence of epithelial and stromal keratitis by about 50%, usually tolerated well. Prophylaxis should be considered in patients with frequent debilitating recurrence, particularly if bilateral or involving an only eye. Standard daily dose of acyclovir is 400 mg twice daily, but if necessary, a higher dose can be tried based on the practice in the management of systemic herpes simplex infection. Continual use for many years has been documented for systemic indications. Prophylactic effect decreases or disappears when the drug is stopped. Excretion is via kidney, so renal function should be checked periodically during long-term treatment. Oral valacyclovir 500 mg once daily. Famciclovir as alternative, probably as effective as acyclovir, require less frequent dosing, may be better tolerated. Topical oral prophylaxis tend to be preferred to long-term topical administration, as epithelial toxicity may occur, leading to mild blurring, persistent discomfort, allergy and functional stenosis are the problems. Vaccination strategies are under investigation. So long-term use of oral acyclovir reduces recurrence rate of epithelial and stromal herpetic disease. The complication: there is secondary infection for microbial keratitis, glaucoma secondary to inflammation or chronic steroid use. It may be undetected. There is poor view of optic disc. Corneal thinning distortion may give rise to inaccurate reading on applanation. Alternative forms of tonimetry may be superior. Cataract due to inflammation, prolonged steroid use. Iris atrophy due to keratouveitis. Keratoplasty. A trial of a rigid contact lens is often worthwhile prior to committing to surgery. Recurrence of herpetic eye disease and rejection are common, threaten the survival of corneal grafts. Topical antiviral given during rejection episode may reduce epithelial viral reactivation. Toxicity may delay reepithelialization. Prophylactic oral acyclovir improves graft survival, should be given to patients undergoing penetrating keratoplasty for herpetic eye disease. It should also be considered in patients with severe atopic eye disease but no history of ocular HSV involvement. The duration of treatment and the optimum dose has not been established. Immunohistochemistry should be performed on the excised tissue to confirm the presence of herpetic antigens. The next topic is herpes zoster ophthalmicus. Herpes zoster is common. It has been estimated 1 in 3 people will develop herpes zoster ophthalmicus in their lifetime. Most patients are not immunocompromised. Herpes zoster ophthalmicus HZO. It is the term used for shingles involving the dermatome supplied by the ophthalmic division of trigeminal nerve. Ocular involvement can also occur, though is rarely clinically significant, when the disease affects the maxillary division alone. Varicella zoster virus VZV causes both chickenpox and shingles. VZV belongs to the same subfamily of the herpes virus group as HSV. The viruses are morphologically identical, antigenically distinct. After an episode of chickenpox, the virus travels in a retrograde manner to the dorsal root and cranial nerve sensory ganglia. It may remain dormant for decades, with reactivation thought to occur after VZV specific cell-mediated immunity has faded. Re-exposure to VZV via contact with chickenpox or by vaccination may reinforce immunity, protect against development of shingles. Mechanism of ocular involvement. Direct viral invasion may lead to conjunctivitis and epithelial keratitis. Secondary inflammation and occlusive vasculitis. It may cause episcleritis, scleritis, keratitis, uveitis, including segmental iris infarction, optic neuritis, cranial nerve palsies. Inflammation and destruction of the peripheral nerves or central ganglia or altered signal processing in the CNS may be responsible for post-herpetic neuralgia. Cicatrizing complications may arise following severe eyelid, periocular, skin or conjunctival involvement. Reactivation causes necrosis, inflammation in the affected sensory ganglia, causing corneal anesthesia that may result in neurotropic keratopathy. Risk of ocular involvement. Hutchinson sign. It describes vesicles in the skin supplied by the external nasal nerve, which is a branch of nasociliary nerve, supplying the tip, side and root of the nose, and ophthalmic herpes zoster. This sign correlates strongly with the ocular involvement. There is no apparent correlation between the severity of the nasal rash and that of ocular complications. Age. HZO occurs most frequently in the 6th and 7th decades. The elderly signs and symptoms tend to be more severe than in the young of longer duration. AIDS patients tend to have severe disease. Shingle can be an early indicator of HIV infection. Lower threshold for HIV testing should be adopted in population of particular risk. The development of shingles in children or young adults classically has prompted a search for immune deficiency or malignancy, though the requirement for this has been questioned, as an abnormality will be found in only a small minority. So, vesicle involving the tip or side of the nose precede the development of ophthalmic herpes zoster. It is known as Hutchinson sign. Acute shingles, the general features. There is prodromal phase. It precedes the appearance of rash. It lasts 3 to 5 days. Is characterized by tiredness, fever, malaise, and headache. Symptoms. There is superficial itching, tingling, burning, severe boring, lancing pain, either constant or intermittent. Older patient, early severe pain, larger area of involvement, particular risk of post-herpetic neuralgia. Skin lesions. There is painful erythematous areas with a maculopapular rash develops. May be confused with cellulitis or contact dermatitis. The rash respects the midline, which may aid in distinguishing shingle from HSV skin infection. Pain is also marked worse in shingles. Bilateral disease is very rare. Within 24 hours, group of vesicles appear and these becomes confluent over 2 to 4 days. Although the rash itself does not affect the lower eyelid in HZO, boggy edema of the upper and lower lids is common. Often spreads the contralateral side of the face. So there is boggy edema here, you can see. The vesicles often pass through a pustular phase before they crust and dry after 2 to 3 weeks. Large deep hemorrhagic lesions are more common in immunodeficient patients. Here you can see. The region healed to leave residual skin destruction, deep pigmented scars. Here you can see. Zoster sign herpetic is shingle without a rash. May be more common than previously realized. Zoster sign herpetic, shingle without rash. Disseminated zoster involve multiple dermatome. Organ system may develop immune deficiency or malignancy. With advent of PCR testing, complications such as meningoencephalitis have increasingly been identified in immunocompetent individuals. Investigations in the event that clinical diagnosis is uncertain, typically immune deficiency, vesicular fluid can be sent for PCR, immunomicroscopy. Viremia lasting a few days occur in acute shingle. PCR of plasma for VZV DNA may be positive in 40%, especially in immunosuppressed patient, and particularly useful if zoster sign herpes is suspected. IgM antibodies to VZV are found in only minority of early stage and convalescent patients. Treatment: oral antiviral treatment optically given within 72 hours of rash onset reduce the severity and reduce the duration of acute episode and the risk of post-herpetic neuralgia. The incidence of late ophthalmic complication is also reduced by about 50%. Patient presenting later than 72 hours but still at the vesicular stage derive benefit from treatment. Acyclovir 800 mg 5 times daily for 7 to 10 days, the main step treatment. Valcyclovir is 1 gram 3 times daily. Famcyclovir 250 to 500 mg 3 times daily have more convenient regimens. Better tolerated, leave as effective as acyclovir, at least as effective as acyclovir. Briodine is available in some countries. Fatal interaction with 5-fluoropyrimidine have been reported, should not be used in combination with original 5-fluorouracil. Intravenous acyclovir 5 to 10 mg per kg 3 times daily. Severe cases: encephalitis, moderate to severe immunocompromise. Systemic steroids: prednisolone 60 mg daily for 4 days, 40 mg for 4 days, 20 mg for 4 days. Remains somewhat controversial but commonly used in moderate to severe disease, particularly for neurological complication. Should be given in conjunction with systemic antiviral and should probably be avoided. Steroids should be given only in conjunction with systemic antiviral. Steroids avoided in immunodeficiency. Steroids reduce acute pain and accelerate skin healing. Steroids have no effect on the incidence or severity of post-herpetic neuralgia. Immunocompromised patients require the input of infectious disease specialist. Antiviral treatment should be extended. Intravenous treatment should be optimal. Systemic steroids should be avoided. Symptomatic treatment of skin lesion by drying, antiseptic, cold compresses, topical antibiotic steroid combination. Patient with shingle can transmit chickenpox so that contact with people not known to be immune, particularly pregnant women, immunodeficient individuals, should be avoided at least until crusting is complete. VZV uveitis is considered in depth in chapter number 12. Prevention. Vaccination against herpes zoster reduce the incidence of HZO. Two vaccines are available. Both are approved for individuals over the age of 50. Zoster vaccine live, attenuated live virus with important limitation that efficacy is lost within 10 years. Recombinant zoster vaccine. Two injections required. Two injections has a 10% incidence of local acute systemic reaction. Eye disease. Acute eye disease. Acute epithelial keratitis develops in 50% of patients. Acute epithelial keratitis within 2 days of onset of the rash resolves spontaneously within a few days, characterized by dendritic lesions, smaller and finer than herpes. Taper ends without terminal bulbs. The lesions stand better with rose bengal than with fluorescein. Treatment, if required, is with topical antiviral. Conjunctivitis, follicular or papillary, is common. Occur in conjunction with lead margin vesicles. Treatment is not required in the absence of corneal disease. Topical antibiotic antiviral can be given. Episcleritis occurs at the onset of the rash, usually resolves spontaneously. A mild NSAID can be given. Scleritis, sclerokeratitis are uncommon, may develop at the end of the first week. Treatment: oral fluorbiopropin. Oral steroids may be required for severe involvement. Nummular keratitis. Nummular keratitis develops at the site of epithelial lesions about 10 days after the onset of rash, characterized by fine granular subepithelial deposits surrounded by a halo of stromal hairs. The lesion fade in response to topical steroid, but recur if the treatment is discontinued prematurely. Stromal interstitial keratitis develops in about 5% 3 weeks after onset of the rash. Significant scarring can occur. Usually respond to topical steroids. Can become chronic, require slow tapering. Disciform keratitis, immune-mediated endothelitis, less common than with herpes, may lead to corneal decompensation. Treatment is with topical steroids. Anterior uveitis, in a third of a patient, there is sectoral iris ischemia and atrophy. Posterior uveitis, progressive retinal necrosis, is aggressive retinitis usually occurring in immunodeficient individuals. Acute retinal necrosis can also be caused by VZV. Posterior segment examination should always be performed in patients with HSO, as retinal vasculitis may occasionally occur. IOP is monitored. Elevation can be due to steroid-induced prostaglandin derivatives avoided if treatment is necessary. Neurological complications may require intravenous antivirals, systemic steroids, cranial nerve palsy in about a third. Fourth sex cranial nerve palsy recover within 6 months. Optic neuritis is rare. CNS manifestations are rare. Include encephalitis, cranial arthritis, Guillain-Barré syndrome. Chronic eye disease, neurotropic keratopathy, similar to that seen in HSV, develops in 50%. Relatively mild, settle over several months. Prolonged severe disease occur in minority. Scleritis become chronic, lead to patchy scleral atrophy. Staphylomas is rare. Mucus plaque keratitis develops in about 5%, most commonly between the 3rd and 6th months. This is mucus plaque keratitis. Elevated mucus plaque stained with rose bengal. Treatment: steroid acetylcysteine. Untreated plaque resolve after a few months. Lipid degeneration may develop in eyes with persistent severe nummular disciform keratitis. This is lipid degeneration. Lipid-filled granulomata, similar to those resulting from chronic irritation. The dorsal conjunctiva progress to erythro-calcified concretion. Subconjunctival scarring may occur. Eyelid scarring result in ptosis, cicatricial entropion, ectropion, trichiasis, red notching, madarosis. Relapsing eye disease. In the relapsing phase, lesions may reappear years after an acute episode. May have been forgotten, or eyelid scarring may be the only diagnostic clue. Reactivation of keratitis, episcleritis, scleritis, or iritis can occur. Post-herpetic neuralgia. There is pain that persists for more than 1 month after the rashes heal. Develop in 75% of patients over 70 years of age. Pain may be constant or intermittent. Worse at night, aggravated by minor stimuli called allodynia. Aggravated by touch or heat. Improves slowly over time. 2% of patients affected after 5 years. Neuralgia can impair the quality of life, lead to depression of sufficient severity, a danger of suicide. Patients severely affected should be referred to a specialist pain clinic. Treatment may involve local cold compresses, topical capsaicin 0.075%, lidocaine 5% patches. Systemic treatment may be used in a staged patient, starting from simple analgesics such as paracetamol, then stronger analgesics such as codeine, then TCA such as nortriptyline, amitriptyline, 25 mg nightly up to 75 mg per several weeks, carbamazepine 400 mg daily for lancinating pain, gabapentin 300-600 mg up to 3 times daily, sustained release oxycodone 10 to 30 mg twice daily or both. Thank you so much.